Hello everyone, welcome to this new video. This video series of videos will explain some bases, obstetrics and gynecology, internal medicine, surgery and pediatrics. Before I explain them, I want to explain to you how you can get these bases for free. They are the most updated bases for Krok questions, and they will help you a lot in studying subject wise, so only subjects if you want to start with this. So you go to krokology.com, which is the website I recommend for studying for Krok 2, and you go to English, medicine, then Krok 2, then go to the, after you make of course a free account, and then you go to the subject section again, and then you can choose the subject you want to practice. So for example, obstetrics and gynecology next, and then you can practice about 400 only gynecology questions, most updated to the latest year of booklets, like previous bases hadn't this feature. So make sure to take advantage of this feature, and let's start the explanation. Now we will start with the base of pediatrics. In a maternity hospital, a newborn had been presenting with cough attacks after eating. The child was discharged from the hospital on the 18th day due to a case of pneumonia. During the further 1.5 months, the child has 2 cases of pneumonia. Periodically, there are cough attacks after eating, and especially if the child lies on the left side. Objectively, second degree hypertrophy, isolated moist crackles, and dyspnea. Stool and diuresis are not disrupted. What diagnosis is most likely? So here we have a newborn, and he has cough attacks after eating. So this suggests a tracheoesophageal fistula, meaning there is a communication between the esophagus, right, and the bronchi. There should be normally no communication between the bronchi and the esophagus. In case this happen, then some part of the food can get to the bronchi, right, from the esophagus, and as a result of this, food getting to the bronchi will cause cough attacks after eating. And because the food will get into the bronchi, obstruct them, and cause cough, and then can cause infections, as you can see in this baby, and there are pneumonia cases which are repeated. So this suggests a tracheoesophageal fistula. Next, we have a prematurely born girl, is now 8 months old, and she has dyspnea, tachycardia, hepatosplenomegaly, physical developmental lag, limb cyanosis. There is a parasternal cardiac hump. Auscultation reveals systole-diastolic murmur in the second intercostal space to the left. Blood pressure is 90/0. What disease can be suspected? So the key word here we need is systole-diastolic murmur. This refers to the murmur that is heard in the disease called patent ductus arteriosus. It's a congenital heart disease, meaning we have from birth a heart defect, and this defect is between the pulmonary artery and the aorta. Normal heart, adult heart, we have no communication between the pulmonary artery and the aorta, right? But in patent ductus arteriosus, we have this here channel or duct that communicates between them. Yes, and as a result of this, blood will go through this duct in systole and in diastole as well, meaning when we have contraction of the ventricles, the blood will exit the ventricles, go to the aorta, and will go back to the pulmonary artery, and this is, we will hear murmur on this phase. And during diastole, which is when the aortic valve will close, the blood will go back, and then part of it will also enter the pulmonary artery. So we will have systolic diastolic murmur continuous through all phases of cardiac cycle, and this is called machine-like murmur. This is a important sign here on auscultation of patent ductus arteriosus. It's connected also with congenital rubella syndrome. If there is rubella syndrome in the child, in a newborn who got rubella, and this was one question in recent booklets as well. Next, we have a 4-month-old child was admitted to the surgical department 8 hours after the first attack of anxiety. The attacks happen every 10 minutes and last for 2 to 3 minutes. Vomiting occurred once. Objectively, the child's condition is grave. Abdomen is soft. Palpation reveals a tumor-like formation in the right iliac area. After rectal examination, the doctor's finger was stained with blood. What is the most probable diagnosis? So here we have a young child, and he has attack of anxiety with vomiting, meaning there is abdominal pain with vomiting, and there is like a tumor-like formation, not a tumor, but a growth or like a formation in the right iliac area, like here, right? And the rectal examination, when there is examination of the rectum of this child, the doctor finger is stained with blood. These types of attacks suggest intussusception, which is when a part of the intestine enters another part of the intestine, invagination of a proximal bowel into distal segment. So you can see here part of the small intestine entering the large intestine. This is called intussusception. This produces attacks of pain, like in this patient, accompanied by loud crying, and red currant jelly stools. And this is a key word you can find in your surgery classes, MCQs as well, that because of the bleeding that happens because of this, there is these types of stools with a bright red blood, and also as well as vomiting. The abdominal mass that we spoke about in the right upper quadrant or maybe right lower quadrant iliac area, it's like called sausage-shaped mass, like sausages, because of how like the intussusception happened. The treatment is by pneumatic air enema, which is basically a tube entered to the rectum and air is pumped through this tube so that we push the folded section back to the normal position. Next, we have an infant who has been born at the 41st week of gestation. The pregnancy was complicated with a severe gystosis of the second semester. The weight of the baby is 2,400 grams and the height is 50. The rest of the question speaks about other baby condition. The newborn can be estimated as, so here we have a newborn which has 2,400 grams. The normal weight of the baby is between 2,500 to 3,500. This is normal body weight. So this means he has low body weight, right? Low body weight. He was born at first 41 weeks of gestation. A normal term baby, like he was born like a term, is between 37 weeks to 41 week of pregnancy, right? So this is a full-term baby. So this is a full-term baby with growth retardation, meaning that his growth is less than the normal, right? Premature infant will be less than 37 weeks of gestation, and post-mature will be 42 weeks and more. So our baby here is full term but with growth deficiency. This can be due to placental insufficiency because of defect of the placenta failing to provide adequate oxygen and nutrition to the baby. This can be acute or chronic etiologies. Here the patient suffers from gystosis, which is pre-eclampsia, a disease that we may speak about later, that can lead to decrease nutrients to the baby. As a result of this, he will grow slower and less than the normal. Low fetus weight. Okay. Next, we have a mother of a newborn suffers from chronic pyelonephritis, inflammation of the kidney pelvis, and she had a case of upper respiratory tract infection before the delivery. And the delivery is at term. For a long period, waters were not breaking. Second day of the life, the child developed erythematic rash, and the rash developed into blisters. These blisters suffers with purulent substance, and after Nikolsky symptoms positive, after blisters had lancet, erosions developed in their place, etc. What diagnosis can be most likely? So newborn skin diseases, you have 3 diseases you should know for Krok. Pseudopharynculosis or fasciculopustulosis. These are inflammation of the sweat glands of this newborn baby. Pseudopharynculosis will look like subcutaneous red nodes of the scalp and the face. This is what they say to you in the question. Fasciculopustulosis, from its name, you have vesicles with purulent content on the neck or the back of the head or the buttocks. Looks like this as in the question. Vesicles, here we have vesicles with purulent content. It looks like impetigo neonaturum, which has also vesicles with purulent content, but these vesicles are like larger, as you can see, and when they rupture, they form erosions on the place on them, like these red spots you can see in the picture. So this is what we found here in our patient. There is a seropurulent contents of these blisters, but when we lance them or rupture them, they produce erosions in their place. That's why it's called impetigo neonaturum. Okay. Next, we have important question. You have to understand it's a 9-year-old child was hospitalized for fever up to 39. He has moderate headache and vomiting, and examination revealed meningeal symptoms. Lumbar puncture was performed, and the obtained fluid was characterized by increased opening pressure, transparent, with a cell count of 450 mainly lymphocytes. Glucose levels of 3.6. What agent could have caused the disease in the child? So here again we have meningeal symptoms. Meningeal symptoms tell us that there is irritation of the meninges, which are the layers covering the brain and the spinal cord. This is the meninges, right? And they can be irritated due to bleeding, like subarachnoid hemorrhage, or due to inflammation of the meninges. We call it meningitis. Inflammation of the meninges can be due to bacterial causes, viral causes, and characterized by meningeal syndrome or these meningeal symptoms. First, we have photophobia, intolerance to bright light, and hyperesthesia, like increased sensitivity, headache, neck stiffness, meaning that here when we try to elevate the neck of the patient, there will be stiffness in this area in the neck. Also can be called other question, nuchal rigidity of occipital muscles. It's all the same, like there is here stiffness, inability to flex the neck forward. Kernick sign, it's resistance to extension of the knee when the hip is flexed. So meaning when the hip is flexed, like in this is the hip, it's flexed in this position. Extension of the knee, meaning bringing it to this position, like straight, is hard, and there is a resistance, and this is Kernick sign. Brudzinski sign, it's when we flex the neck, it's caused involuntarily flexion of the knee by the patient. This Brudzinski sign. You find these signs in the question just mentioned, and by their explanation, you need them for your clinical classes and neurology and so on. But for the questions until now, they didn't ask for their how they are performed or what they mean. They just want you to recognize that Brudzinski sign means meningeal symptom. So when you see these symptoms in the patient, you suspect meningitis, right? But to make sure that this is meningitis, we need to do lumbar puncture, which is a puncture of the area of the cerebrospinal fluid to take a sample of the meningeal fluid called cerebrospinal fluid and study it, right? And what we see with in it, we see the color, we see the amount of cells, the type of cells, the glucose and protein, and this can tell us what type of infection or if there is infection or no in this patient. So in our patient, we find that there is a lot of cells, the color is transparent, and all of the cells, or most of them, are lymphocytes, and glucose 3.6. If we compare the table, we find that if the color is clear, it can be normal or it can be viral, can be tuberculosis. It cannot be bacterial. Bacterial, the color will be green yellow, characterized by bacterial infection. It's always with pus, which color is yellow, right? So it's viral or tuberculosis. It cannot be normal because we have meningeal symptoms. In viral and tuberculosis, again, we have both of them. We have lymphocytes. So, and this is, and the question was 90% lymphocytes. But the difference between viral and tuberculosis is the glucose count. Glucose normal is 2.5 to 4 in the cerebrospinal fluid. But in the viral meningitis, it will be normal as well. So it will be also the normal values. In our patient, the patient has glucose at 3.6, right, which is in the normal ranges, 3.6. So we consider this as normal, and this is a difference between tuberculosis meningitis and viral meningitis. Tuberculosis meningitis will have low glucose. They will turn other questions 0.5, 0.6, like this. So this is important to know, that glucose in viral meningitis is normal. I memorize this as like tuberculosis caused by bacteria, and bacteria likes to eat glucose, and when it eats glucose, glucose gets down cerebrospinal fluid, but viruses don't eat glucose, they are normal. So it's a way to remember this. So because of this, it's not Neisseria meningitis. Neisseria meningitis is bacterial meningitis. Mycobacterium tuberculosis, we spoke why it's not true, because glucose will be less than 2.5. Staph and strep pneumonia are all bacterial meningitis, which will have not transparent fluid but yellow, green fluid. So the option here is a virus called enterovirus. Okay. Next, we have a mother of a 3-month-old child came to a family doctor with complaints of her child being physically underdeveloped and suffering from cough attacks and dyspnea. In the history of the disease, the child is the result of the second pregnancy with risk of miscarriage. The first child died. Body mass at birth 2,500. Cough attacks were observed from the first days of life. Twice the child was treated for bronchitis. What disease can be suspected? So here we have a child who has repeated respiratory infections, and he's underdeveloped for his age. It means that his growth is not like the growth of a normal 3-month-old child, right? When you see these types of question, you can suspect cystic fibrosis. What is cystic fibrosis? It's a defect in the chloride ion channels. We have in the body chloride ion channels, and it's a long pathogenesis, but in the end, what we will have is that these chloride ion channels are responsible for making the secretions, like mucus secretions and other type of secretions in the body. If there is a defect in them, then what we will have is accumulation of the secretions and blockage of the small passages. The secretions of our body, instead of them being smooth and with a right amount of water inside them, they will be very thick, right? So imagine a lung airway which is very thick, with very thick secretions, right? These secretions, their normal responsibility is to trap the bacteria, and then these secretions will be coughed or will be swallowed to get rid of this bacteria. But if they are thick, then there will be problems. There will be infections. The bacteria will grow. There can be dyspnea because these secretions will obstruct the airway. So these patients, you may see them, they will require always like these tubes to drain these secretions from them. So this is why this patient has chronic cough, repeated respiratory infections, sinusitis, pneumonias. And because of this, he doesn't get enough oxygen and respiratory infections, has weight loss and growth retardation as in our patients. Also, the patients can have the thick secretions of the pancreas, because pancreas has secretions as well for which increase pancreatic juice, as you know, for digestion of food. And if they have thick secretions of pancreas, then they have problem with digestion of food as well, and they will have pancreatic insufficiency, steatorrhea, which is fat in the feces because inability to digest them, and so on. Important to know as well is that we diagnose this by a chloride sweat test. We see elevated chloride in the sweat, and this is like when you see the word chloride in the questions, it's like a keyword for solving cystic fibrosis, but it's not present here. So pay attention to this as well. This is like how the patient looks like who has cystic fibrosis, malnourished, bronchiectasis and bronchopneumonia, combination of secretions, and pancreas as well. A boy was born at 32 weeks of gestation. 2 hours after the birth, he developed respiratory distress. Respiratory severity was assessed by Silverman score, and respiratory disorders progressed. Respiratory failure could not be eliminated by CPAP, continuous positive airway pressure. X-ray of the lung shows reticular and a nodular pattern, broken ground. What is the most likely cause of respiratory distress syndrome? Very important question. 2023 booklet, we had 2 questions in one booklet about this disease. This disease is called hyaline membrane disease, or fetal respiratory distress syndrome. From its name, it's fetal respiratory distress. There is problem with the respiration. There is respiratory failure in this fetus. And why it happens? It happens in preterm infants who are born before 37 weeks of gestation, so about 34 weeks, 32 weeks, as in here in the question. And what is the problem if we have a preterm infant? There are many things that are immature organs and so on, which didn't complete maturity, and one of them is the lung. The lung is not mature enough and cannot expand as like a normal lung because of mainly of the absence of the surfactant substance, which is a substance that keeps the alveoli open, okay, and ensure good respiration. So in preterm infants, we will have alveolar collapse and respiratory failure. It's present at birth, as in our patient. We will have problems at birth. There will be tachypnea, increased respiratory rate, hypoxemia, and as you can see in this picture, there is like paradoxical movement of abdomen and chest. When the chest will go down, abdomen will go up. It's also a sign of this disease. Intercostal retractions, visible ribs when respiration because of the effort to make respiration. See here as well, flared nostrils which are widened in order to get as much oxygen as possible. So on X-ray, the diagnosis will be, on X-ray there will be air bronchograms, as in the question they say X-ray have air bronchograms, and this means we have visible air in the bronchi. It's one finding in this disease. Also other things. In the treatment, which I didn't here include, but the treatment should be, of course, surfactant administration, because it's all because of deficiency of surfactant. So surfactant administration. And this was one question 2003. So air bronchogram, preterm infant, you should suspect hyaline membrane disease or fetal respiratory distress syndrome. Next, we have a woman with blood group B Rh positive, gave birth to a full-term healthy boy. Examination on the 3rd day of the infant's life shows him to have ecteric tint to his skin, like his skin is a bit yellowish, right? The child has no problems with suckling, sleep is non-disturbed, abdomen is soft, liver, complete blood count, erythrocytes 5.5. Total bilirubin, indirect bilirubin, what condition can be suspected? This is also important question to know if the child has normal jaundice, physiological jaundice, or pathological jaundice. What is jaundice? Jaundice is yellowish discoloration of the skin and sclera. As you can see here, this baby has yellowish discoloration of the skin, but it can be normal in newborn babies, or it can be abnormal, and it's important to know because if it's so we can prevent complications. What is normal, what is not normal? Physiological jaundice, here you can see how it happened, why it happens, but I'm interested in when it happens. Physiological jaundice happens on the third day of life, okay? Like meaning on the third day of the newborn life, it can happen, okay? Or it cannot happen at all, but if it happens, then it happens at the third day of life, not before. In contrast to pathological jaundice caused by hemolytic disease of the newborn, this is jaundice due to blood group incompatibility, meaning that in the blood of the child there are red blood cells which are Rh negative, and there are his mother was Rh positive, and because of this, without too much details, this is like separate topic. Because of the mother's blood Rh positive, she has anti-Rh antibodies which will attack Rh negative blood of the baby, right? And this leads to rupture of red blood cells of the baby and releasing of the bilirubin, which is a substance. If it's increased, it will cause jaundice. So as a result, we will have jaundice. But these types of jaundice, due to Rh group incompatibility, or it can be incompatibility between A, B, O blood groups, B, O, or O, then it happens at the first day of life, okay? It doesn't happen at the third day. Moreover, in the physiological jaundice, we will have normal condition of the child. The child will be healthy, will be sucks the breast good, he sleeps well, and his crying is he's not like hypo, has normal movement, has normal reflexes, and so on. In contrast to the pathological jaundice, his condition is poor, he doesn't eat well, he sleeps poorly, and so on. Back to our patient, or our child, he has no problems. He has on the third day the jaundice, and he has no problems at all. He's completely healthy. So that's why it's physiological jaundice. It's not hemolytic disease or Rh or something else. Here we have a child who has a hyperbilirubinemia, increase of bilirubin. Again, bilirubin is a substance that is the result of breaking down the red blood cells, and when they are broken down, bilirubin will increase in the blood. This increase in the blood will cause jaundice. Bilirubin gives the yellowish color. And this person developed disturbances manifesting as periodical excitation and convulsions against the background of inertness, hypotension, and hypodynamia, and inhibition of unconditioned reflexes, convergent strabismus, rotation nystagmus, and setting sun ice phenomenon. What is the most likely cause of such symptoms? So this is pathological jaundice. How do I know this? Because the child condition is abnormal. He has hypodynamia, he's not moving well, he has reflexes which are not normal. Furthermore, he has neurological symptoms, especially the eyes. Eyes are like convergent strabismus, rotation and nystagmus. The eyes are like nystagmus means the eyes are like moving up and down very fast. It means there is neurological disturbance of the child. There's hypotension, convulsions, like twitching of the muscles, and so on. This is a severe complication of pathological jaundice, especially jaundice because of blood group incompatibility, right? Either Rh blood group incompatibility or ABO blood group incompatibility. So what happens is that because of mixing of the mother's blood and the fetus blood, in the fetus blood we have a lot of This is what I mean. This picture in the first pregnancy and the second pregnancy. So let's explain this disease. We have first of all blood groups which are called Rh, right? There are red blood cells which have this blood group on them, we call them Rh positive, and we have red blood cells which have no Rh on top of them, we call this blood group Rh negative. So if the baby is Rh positive and his mother is Rh negative, then at first pregnancy nothing happens, but we call that the mother will develop Rh positive antibodies called anti-Rh. They look like this. Yes, these anti-Rh. This is after the first pregnancy, because these antibodies takes time to develop. Okay, so the first baby, even though that he is Rh positive, he will not be attacked by these anti-Rh positive antibodies, but who will be attacked by them is the second baby. He will have like bad luck, because these anti-Rh antibodies will be ready in the second pregnancy. They will be developed, they will be ready to attack the child's body in the second pregnancy. And what they will do, they will attach, as you can see, they are the blue ones here, and they will attach on the top of the red blood cells and then lyse them, right? And the result of this, we will have like lysed red blood cells, and these red blood cells will release the bilirubin. Okay, the bilirubin is now released, right? And what is the problem? It can cause yellowish discoloration of the skin, yellowish color of the skin, and so on, but nothing else, right? No, it can, if the bilirubin levels increased a lot, it can cause bilirubin encephalopathy or kernicterus. Like bilirubin damages the central nervous system, causing neurological complications that can lead to permanent damage of the brain, like convulsions, manifested by convulsions and hypertonus of the muscles. Looks like this: spasticity, mental retardation. So this is the complication. So what's happened in this child is convulsions because of very high bilirubin. They didn't tell us about the blood groups story and so on, but as I tell you, this is a complication of, as you can see, he is like 3-day-old infant. Okay, so he developed at the first day probably the symptoms, and by third day the bilirubin levels increased a lot, so it damaged his brain already. So what happened here is bilirubin encephalopathy. So some questions, as you can see, need explanation in pediatrics and in general Krok 2. You need to know the story behind them, so that's what I'm trying to do. This was pediatrics base. And as last, I want to announce about our course with Krokology that includes the explanation of Krok 2 booklets the same way we explain these bases. So if you like these videos, make sure to check our course, which starts from January next year. And for more videos, make sure to follow this channel.